Thanks, Angie. Well, hi, everyone. My name is Sue Rail. I'm a healthcare manager with Eide Bailly. I've been here, I believe, 19 years. I've got a little chalkboard on my desk where I write, I won't say inspiring messages. For a long time, it was waiting for ICD, but a couple weeks ago, I changed the message to, I thought growing old would take longer. So those of you that know me know I'm old. And I've been with coding for decades. We'll just put it that way. And everything's changed. Things have changed. Of course, we had ICD-10, but just through the years, all the different payment programs, all the different rules, there's nothing constant in healthcare. And so we always need to just touch base and check in with each other, check in with the contractors, the payers, the coding guidelines, the CPT guidelines, the billing guidelines. And that's what today is, just kind of a check-in. Let's see what everybody's talking about. Let's see if we're doing the right thing. And so that was why I named it Coding Corroboration. What a word to pick. And compliance. Because one without the other will never meet all the necessary requirements. So we'll get started. This figure is, if you notice, from 1996. So we're talking 20 years ago already. CMS was looking at, and the OIG, $23.2 billion in errors in claims. Now, this isn't talking all the fraud that's going on behind the scenes in all the, fake claims, fake patients, all that. This is on billing errors. So number one, figure one, we're talking about lack of documentation, insufficient or no documentation to substantiate the claim that was submitted, lack of medical necessity, incorrect coding. Now, if you notice, incorrect codings down the line, we're not doing that bad. Non-converted or unallowable service or other, 2.67%. Documentation, definitely way at the top. So this was 30% of all claims contained errors. That's a pretty high number. Figure two broke it down by what was the care setting. So the highest number in inpatient, now this was including PPS, physician claims, 21.68, home health, then outpatient, then SNF, then lab, and then other. So have we improved since 1996? I'm afraid not. And of course, charges are higher, reimbursement is higher, even though we don't feel like reimbursement is higher, it is. So we're still talking we're talking billions of dollars in errors that we want to catch, and facilities want to do things correctly. I know they do, but they also want to get reimbursed what they're due. So in 2010, the OIG looked at just E&M errors, $6.7 billion of incorrect E&M code assignments. For any of you that are on the line that aren't coders, the E&M is the evaluation and management codes assigned to report physician services, primarily clinic visits, but will also be for outpatient, emergency room visits, hospital, inpatient, outpatient, swing bed, also in the skilled nursing facility, to report their services to payers. So 42% of the claims for E&M services in 2010 were incorrectly coded. So we had upcoding, downcoding, 19% were lacking documentation. And then also the claims from the high coding physicians were more likely to be incorrectly coded or insufficiently documented than claims from other physicians. So in essence, what they're saying is the very high level E&M codes were more often incorrect from the physicians that routinely billed high levels. Physicians within these slides, within information from OIG, CMS, almost any other source, means providers will include your mid-level providers. So 2013, we're getting a little closer. You know, Medicare data is always behind. 36 billion was lost to overbillings by providers in fiscal year 2013, with hospitals accounting for 88% of the waste. Again, upcoding. Now, when we're talking hospital upcoding, that's frequently meaning DRGs to get to a higher DRG, to a higher APC, but it also can be in any setting that higher levels were assigned than appropriate in ED or in a surgery or medical necessity. We can upcode to provide medical necessity that isn't really there or isn't present in that record. So even we have well-meaning providers, clerical errors on Medicare claims drain billions every year. So the error rates from 2012 to 2013 jumped almost 2%. 1 year, that's only 1 year. So here's where we start with the rules. Conditions of participation. Every hospital that receives Medicare funding or Medicaid funding is subject to the federal conditions of participation. You should be very familiar with them. In the CAH, these are primarily the rules that you're surveyed on, and also in the PPS. But it's sometimes surprising how often we do a review or we go into a facility and the staff members really have never heard of the conditions of participation. So we need to verify. This is just verbatim out of the conditions. Verify the patient records contain appropriate documentation of practitioner orders, interventions, findings, assessments, records, notes, reports, and other information. So this involves that corroboration. Every department is included here. We have the practitioner's orders, the interventions from every department that cared for that patient, their findings, their assessments, the records, the reports, we're talking lab, x-ray, every other department, all has to be there because those are the services we're reporting on the claim. So every line item you're reporting on the claim has to be substantiated in the medical record. Compliance. ICD-10 and CPT coding guidelines for the coding staff. This is the baseline. This is where we go. This is where we go back to assure proper coding, proper reporting. This is where we go back to the physicians and the providers to say, yeah, but the rules here say this. As I noted, the federal conditions of participation, and that little blurb I had before was exactly that, a tiny, tiny little blurb. There are lots of rules in the conditions. Now, a lot of them affect many other departments and aren't closely tied to billing, but for coding and reporting and documentation, that's kind of our Bible in the conditions of participation. And then we have all the Medicare and other third-party payer regulations, which we have to kind of stack into, layer into the CPT and ICD-10 regulations, the Code of Participation, the Medicare benefit manual plays in, and we have a lot of rules to live by. Compliance in the EHR. This is one of probably the biggest concerns. Currently and in the recent past, medical necessity isn't new, and issues with medical necessity is not new with the EHR. but it has been extremely compounded when we look at a record that has been generated through templates, check boxes, auto-population, and sometimes that's all we're seeing. We're not seeing free text. So you look at the same record from day to day to day, and it looks exactly the same. If you didn't have good documentation in your paper record, more than likely you have nothing better in your EHR. There might be more documentation, and we'll see that because we get records downloaded into our client portal to do record reviews, and I can get a same-day surgery record and get 215 pages. So there's a lot of documentation. A lot of that's carryover and depending on how downloads occur, but the documentation is prolific. The individualized documentation to the patient is minimal in some records, not all. Timing of records is probably one of our biggest concerns, in that the time that shows up in the record is the time of the entry, not the time the actual service occurred. And that can create great conflicts within the medical records from a compliance standpoint. So if you're going to have an external coding review, and as Angie noted, we have participated in several external coding reviews through the Flex grants, and that's been, I think, just a wonderful opportunity for providers and facilities in North Dakota. And of course, it's been an opportunity for us to share our experience with facilities throughout North Dakota. So if you're going to have an external coding review, you definitely want to have goals. What's your goal in performing this? Is it just to meet somebody's requirement? Are there specific needs? Are there specific areas you have definite concerns? And once you have your goals, then you definitely can go to your executive team to get that support, and you can discuss it with your staff, you can discuss it with other departments, and then start to identify the cases you want reviewed. But when we talk about documentation, nothing's changed. If it wasn't documented, it wasn't done. That's been around as long as I've been in healthcare. You can't report a service on a claim until the documentation is complete. And that's been an issue in the paper record, and it's going to continue to be an issue today. So basically, all test results must be present on the record prior to billing. We will, on occasion, have some labs that are the titers that are going to, keep coming back for so many weeks, and then, some are even as long as a month and another 3 months or something. Those are very, very unusual cases. But until you get that report back, you have, to verify that the service actually occurred, you shouldn't be releasing that claim. Health information management should be responsible for the final review before coding and release of the claim. Sometimes there's some confusion in that, oh, now we have an electronic health record, that's more an IT issue. The medical record in the paper format, in the hybrid format, in the electronic format is still the medical record, which belongs under health information management and is their responsibility to assure all the I's are dotted, the T's are crossed, the reports are there, the documentation is complete. It's a different format of review than we did in the paper record, but somebody has to be responsible for it. And it's ideal to be doing it as the end process once the entire record is complete and the patient has been discharged. So back to the external coding review. You want to do, sometimes staff get a little nervous or defensive about having their work reviewed. And we have reviews of artwork. And we really While we still get a little, oh boy, somebody's going to review my work, we certainly welcome it. We want to know if there's another opinion out there and how we should be doing things. We review each other's work because we want to all be on the same page. And there are many areas that require interpretation in coding and billing. We all know that. And so you have to really analyze some issues to determine what's the best way to code this or bill this. So we certainly recommend coding reviews as educational. They should drive education for each of the staff. You're going to find, oh, this coder needs more education or more assistance and training in this area, where another coder, you know, has some issues, or we might find primarily billing issues. So it should not be a punitive use of a review. You definitely want to use it as an educational tool. So coding and billing go hand in hand, and education is definitely the key. ICD-10, CPT, the UB, billing methodology, depending on your status. If you're a CH, if you're an RHC, if you're a provider-based RHC versus a freestanding RHC, and whether or not your method 2 billing with your providers. These are all essential issues for everyone to at least have some grasp of. You don't need to have your billers fully understand all the ICD-10 rules, but they have to know there are rules, and they have to know that they can't change codes any more than coders can go in and just say, well, this just isn't going to work, so I'm just going to delete this CPT code that came from the Chargemaster. Everyone has to understand each other's rules and roles, and the better, especially your coding and billing staff, work together, the cleaner your claims are going to be, and the better everyone's going to get along. Here's some of our top 10 frequent findings. Number 1, no doubt, infusions, injections, and hydration services. 2, coding from the past history or the problem list. Those are really just should be off limits to coding, other than assigning history codes. Matching diagnosis to medications. This is old school. I've been there. I've done that. There was a time period where that was felt to be acceptable. Go down the list of the past history. Oh, let's see, they say CHF. Oh, let's look at the medication. Oh, they're on Lasix. Okay, we'll code CHF. That's, you know, still being treated. That's really beyond our scope of clinical knowledge. And I have certainly found over the years, sometimes they're on a med for a different purpose than that diagnosis in the past history. And it really isn't our place. It is the provider's place to document their current diagnosis, and if they're being treated or not, if they're being monitored or not. And there are some pertinent past history diagnoses that should be captured. History of a amputation of a leg, or in some facilities they code all histories of implants such as pacemakers and joint prosthesis. But we don't want coders determining what's being treated and what isn't. And then we have incomplete current diagnosis documentation, and this is found in the majority of the records that we review. That providers, they think the problem list has replaced the current diagnosis list, and it hasn't in any way, shape, or form, because those problem lists have a multitude of diagnoses, some that have been ruled out. There's many, many duplicates with variations from one visit to the next, and they aren't maintained. Issues that have been resolved or ruled out haven't been removed. So we certainly do not recommend coding from the problem list. E&M levels, up-coded, down-coded. Coding guidelines, a lack of knowledge of coding guidelines is not unusual. And while they did change from ICD-9 to ICD-10, the basic coding guidelines, for the most part, have stayed the same. We've had some updates. Last year we had big updates, but they definitely need to be studied and reviewed and discussed. Screenings versus diagnostics. We see quite a few errors in that, both between the provider documentation and the codes assigned. Insufficient queries. We tend to see that critical access hospitals don't query nearly as much as they need to. Your data is as important as the PPS hospital down the road, down the highway 100 miles away. Your data is being compared to to PPS facilities. If I go out to look up your data on ahd.com, I find DRGs. In the ever-changing world of healthcare, as we talked about earlier, we don't know. We don't know what the systems are going to be, the payment systems are going to be down the road. We don't know what it's going to be next year. If the critical access hospital payment methodology went away, you want your data to accurately reflect the severity of the patient condition that you treat. Well, Rhonda will be discussing that when she discusses HCC reviews or HCC assignments also. So don't hide behind the fact, oh, it doesn't matter how we code it because we'll get paid anyway. You want to make sure you're coding accurate and really reflecting the condition of the patient. Lack of medical necessity, that's a big issue in getting claims paid, but even on retrospective review, look at a record and say, why is this patient here? There again, it ties in with the EHR when everything's negative, checkbox, auto population from both nursing and physician staff. But they can order a multitude of tests and everything's normal, and then a bunch of them get ordered again the next day. Why? I mean, on review, just the fact that there was a diagnosis to cover it may not substantiate the service. Where did that diagnosis come from? We seem to come across probably more in the lab area in clinic records that coders seem to be going hunting for diagnosis to cover tests, which isn't allowable. Each record has to stand alone. Each clinic visit, each ED visit, they really have to stand on their own. So if the documentation isn't there for the medical necessity for a test or a service or a surgery, then that record needs to go back to the provider, because they need to explain why they're ordering that test or service or scheduling that surgery. You can always pull in other information if the provider refers to it. If they say, see their clinic visit, see their ED visit from yesterday, from last week, that kind of thing. But if it's not there, you just can't go digging through the record to try to find something to cover a test. Number 9, possible, probable, likely. And we're talking diagnosis. On the inpatient side, you can only code these diagnoses if they're documented as possible, probable, likely at the time of discharge. We tend to still see codes assigned that maybe in a progress note said possible dehydration, and then a code is assigned for it. So that rule is in your coding guidelines. That only applies if the diagnosis is documented as such at the time of discharge. On the outpatient side, you can't code those diagnoses at all. And that too is in the outpatient coding guidelines. Reporting an E&M and a minor procedure. Because of the methodology of signing CPT codes, and while the hospitals aren't affected by global periods, the documentation it's out there from Noridian and within the NCCI manual for hospitals, not just for physicians, that when we're talking minor procedures, we think of things like laceration repairs. So if the patient comes into the office or into the ED and they come in, the nurse does their vitals, their basic drug medication list and a brief history. Provider does the same thing, and all the attention and all the documentation otherwise is focused on the laceration repair. And you could not pull out a separately identifiable E&M from that documentation. So only the procedure should be reported. And there is a lot of variable in the circumstances, but all workup related to a procedure is encompassed in that procedure code. It's not a separately identifiable visit. So we do still find quite a few of those. So frequent billing findings, missing charges. EKGs tops the list. I don't know what the issue is, and I would say EKGs performed in the ED. We frequently find that these CPT codes are not on the claim. Or we'll find them on the claim and we find no order. Very rarely would I say we don't find the test result. So because maybe they're verbal orders, and some places nurses do the EKGs, other places they call in another department such as RT to do the EKGs, somehow those charges seem to be getting missed. Self-administered drugs, revenue code 637. All oral medications are considered self-administrable drugs, and there is a very specific list out there from Noridian that lists the other drugs that are considered self-administrable. And so you should have that list within your files, and you should be reviewing it when you're looking at your Chargemaster and how you're assigning and reporting those codes. If the drug is on the self-administrable list, let's just take insulin. Doesn't matter how insulin is administered. It's not reportable as a 636 revenue code, or the administration of the drug is not reportable because it is considered self-administrable. There are some opportunities out there to appeal those rules per se, like say for the patient who requires an IV administration of insulin, which either again you can find on the Noridian site. Unbundling, we still see some unbundling of codes, misuse of modifiers to unbundle codes. They have to have a good reason to unbundle them, not just that this is the way we do things. Again, on billing, screening versus diagnostic, DME codes on hospital or clinic claims. Very, very few rural providers have a DME license. If you have a DME license, you should be billing any DMEs on a DME claim. You have a different NPI number. Albuterol with the nebulizer treatment is the most frequent. The HCPCS code for albuterol is a DME code and should not be reported on a CAH claim or a hospital claim at all. And it is albuterol is considered included in a nebulizer treatment. Now, probably a good time to say, most of these charges, most of these codes will make it through on the claim. We get lulled into a false sense of security with how we're coding and how we're billing because they don't come back. We don't know why they don't come back, honestly. We do know there are some very specific edits that the Medicare contractors have had to turn off when processing CAH claims, such as the inpatient only edits on an outpatient claim. Because of the way that we are required to bill in the CAH and the two separate claims for outpatient and inpatient, there are times that you have to report a inpatient only CPT code on an outpatient claim. But we have found more and more and more edits are turned off. So those DME codes go through. Incorrect infusion and injection codes go through. More than one initial infusion for an outpatient stay on the same claim goes through. It shouldn't. I'm trying to think of some other examples, but I know that 24 hours of observation, more than 24 hours of observation, or no, of hydration does not go through. So if you try to put 26 hours of hydration or infusion on one line item, it won't go through. But every day I'm amazed at what I find incorrect that should be hitting a billing edit goes through on a CAH claim. So like I said, don't be lulled into a false sense of security that you're doing things correctly just because you got paid. And then also remember, they're not looking at your record. It's just claim edits. Units of drugs, units of observation, units, hours, however you want to say it, of infusions and injections, very frequently billed incorrectly. Incorrect provider, incorrect place of service, incorrect discharge status codes, and then dates. This one's definitely down, lower on the list, but at times we find charge dates and from and through dates incorrect, frequently on ED and observation, or the ED and observation, or one or the other going to an inpatient claim, and the dates are on the incorrect claim. So again, we'll look at verify that the patient records contain appropriate documentation of practitioner orders, interventions, findings, assessments, all of that. All ties in with coding and billing. So documentation, it is definitely the very, baseline of supporting the services that you are reporting and performing to support admission. We really have to be looking at what's appropriate to admit, what's the appropriate status to admit to. Supporting hourly observation charges and admission from observation to inpatient. We really find a lot of issues with that, in that facilities and providers keep a patient in observation for 48 hours and then change to inpatient when all the really acute services have been completed. And there is no medical necessity for an inpatient stay at that point. A short stay to support a 1 or 2 day stay. Frequently that documentation just is not there. Medical necessity of a surgical procedure. We're looking closer and closer. We see Medicare and Medicaid and other payers looking closer at medical necessity of surgeries to support lab and x-ray procedures, and also the documentation to support an E&M level. Sometimes some facilities have the providers assigning their own E&M levels. Some review, have the coders review, some don't. They should always be reviewed because providers know what they did, and that's how they base their E&M assignment. E&M assignment has to be provided, or has to be assigned on what they documented, not what they did. It should be both, and they should be the same. Excuse me, but the documentation is what has to support it. So where's the corroboration? Providers to coders, nursing staff with coders, billers, and providers, ancillary staff, coding, billing, and the Chargemaster, billing staff, coding, and the Chargemaster, Chargemaster staff, billing, coding. Now I realize in your facilities, a lot of these people might be the same people, but there's so many ways that that corroboration, that education has to flow. So coding. Coding definitely means ongoing education. Ongoing, ongoing, ongoing. We're still learning ICD-10. We're only a couple years in. I mean, this is a massive system. It's a great system because we have so much better specificity, but it takes a lot to learn it. So we really need to continue on the coding guidelines in ICD-10, coding clinic. these are some big coding clinics that have come out over the last few years, and we have to frequently go back and review them, but we should always be reading them when they come out. Some things aren't going to pertain to your facility or your providers, and that's okay, but you never know when they are. Something different's going to come up. CPT guidelines and CPT assistant go hand in hand for your E&M and your HCPCS, or your E&M and your CPT codes. And then CMS evaluation and management guidelines are very beneficial. And then the Medicare benefit manual. And you'll find the rules that apply to and maybe sometimes don't agree with the other guidelines. And so we have to be very careful on that and make decisions on how we're going to address those differences. External education is always important. And I know that there's not a lot of funding out there available for continuing education in facilities, but if you're missing charges, if you're missing billing something correctly, that this information is out there and has been out there, but you just haven't given your staff, whether that's coding or billing or nursing, the opportunity to learn about it, to do it correctly. And then the other piece is, if you have to pay back a big chunk of money that maybe could have been prevented by adequately educating your staff, you'll definitely regret that in the future. So, but you know what? CMS and Noridian offer a lot of education. There's no charge for their education. Noridian is excellent when it comes to webinars and audio conferences and Ask the Contractor. You could sign up every week for some type of education. So you really need to be on their mailing list and look closely at what's offered. And they go very specific into critical access, hospitals, swing bed, nursing home, observation, infusions and injections. They just offer a wonderful variety. AHIMA, if your coding staff is credentialed, and they have a lot of resources available on the AHIMA website. Once a year, we have a North Dakota HIMA conference with education, which is coming up in September. And then there's the AAPC for your CPC certified coders. They offer a lot of education too, and then usually local meetings in different parts of the state. So reviews, you should have a compliance plan. You should have an internal compliance plan and an external compliance, oh Lord, it's Monday, sorry people, external compliance plan. So if you have internal staff, if you have enough internal staff to do reviews yourself, that's always a good baseline to hit. If you don't, then you should really be looking at external reviews. And you have to determine what your capability is. They can be ongoing with specific charts, or it can be quarterly, it can be yearly. You can do focus reviews on previously identified issues you've had concerns with. If you outsource your coding services, you definitely should be getting external reviews. We do outsource coding, and we are in a lot of the facilities reviewed by an outside agency on behalf of that client. And I mean, you have to be able to assure you're doing things correctly, that your services are being coded and billed correctly. So keep going, keep developing, keep coming up with a plan. If you haven't started one, now's the time to start. But when you're doing outsourcing, I mean, you need to be checking internally yourself with whatever qualified staff you have, but you should definitely have an external review at the end of year one, and then periodically, depending on the findings of the review. Or you may need to go out and look for a new company after the findings of year one. So let's talk about provider education. And I'm not going to spend a huge amount of time on this. I've got several slides, but clone documentation, and you can call it what you like: cloning, cutting and pasting, carrying forward, auto-population. Basically, now this is back in 2006. There again, we're talking over a decade ago. We do not, CMS says we do not expect that every patient had the exact same problems, symptoms, and required the exact same treatment. And we see this over and over and over again. And when the patient's condition doesn't change from one day to the next, and when you see the same typographical error from one note to the next, you know very well that that note has been just carried forward. And that does nothing to support the medical necessity of the services that you're providing, and it also does nothing to benefit the patient. That it questions, is somebody even actually assessing this patient, treating this patient? First Coast Options is an old Medicare contractor, but they've did some very good work and documentation. And it's very clear, and this is clear from the OIG and clear from CMS, that all documentation medical record must be specific to the patient and his or her situation at the time of the encounter. And cloning is considered misrepresentation of the medical necessity requirement for coverage of services. They go so far to say that, you know, if they find this type of documentation, it could lead to a denial for lack of medical necessity and recoupment of all overpayments made. This is serious language, and it's a serious situation in that it's seen repeatedly. And while there are certain things that there's an expectation almost that you will see the same information and that the EHR is of great benefit when you're talking family history or even pulling forward the past medical history and updating it. Otherwise, when you're in physician documentation, when we're talking about HBI, chief complaint, review of systems, physical exam, none of that should be the same. You can have a template that addresses the body parts that you should be examining, you know, those kinds of things. We see frequently the normals. If you click the box, the normal will auto-populate. This always, almost always, creates conflicts in the record, because in the review of systems or the physical exam, there'll be a conflict with the chief complaint or the HPI, or there'll be a conflict between the physical exam and the review of systems. I can't tell you how many times I've seen patients with strokes and stroke extensively documented in the past history or, you know, in the HPI, and then in the physical exam, they're moving all four limbs normally. Or perhaps they're blind in one eye and you get to the physical exam and both eyes, you know, respond equally. It always creates conflicts. So providers have to be educated and have to be monitored on the use of cloned and auto-population and whatever you want to call it, template documentation. When providers are assigning codes, whether those are ICD-10 or CPT codes, E&M codes, they must be reviewed. They just have to be reviewed. They're not trained in coding. They can know the high level, but they're not trained coders. And I'll just say, I believe you're asking for trouble. They can become better at it as long as they understand that they need to ask for help. E&M is probably easier to have providers do as long as they pay attention to what they're documenting. ICD-10 is difficult at the least. So who has the final say, though? We hear a lot about conflicts between coders and providers, and when coders want to change the provider assigned codes, and we hear concerns from the coding staff that administration wants to side with the providers. So you have to have a policy, a procedure, kind of some rules in place on if you're going to go that route, then somebody has to have the final say. Queries, when to query. When there's insufficient or unclear documentation, if there's diagnoses that have been lost, and I call lost diagnosis those that were documented early on in the stay, and if there were significant diagnoses, such as dehydration, and then they never got mentioned again. Well, perhaps they should have. I mean, they can be as significant as respiratory failure that's documented on admission, and maybe the next day, and we have a 4 or 5 day stay, and then, you know, they got better, and that diagnosis didn't get documented again. It didn't even get addressed in the discharge summary. We really need to query on those. Final test results, as long as the provider has noted that the test result is still pending, and or say, you know, talking about the condition that the patient is, you know, that he's concerned with, and this test showed this, or this result today showed this. This we'll do another one today before, and then the patient will be discharged. You can ask that provider to amend it. What you can't do is note on your own that the test was very abnormal, that the provider didn't note and didn't really acknowledge in any way. You can't introduce new information into a query. So nursing, education about coding, education about billing, consistency and documentation is huge. Documentation in the same place by every staff member on specific issues, start times, stop times, infusions, injections, hydration. This is the biggest issue we probably have with those services, is a lack of stop times. And as we get bigger and bigger EHRs, we're digging all over, researching, you know, here, there, and everywhere to try to find somewhere that someone might have documented a stop time. So that should be a nursing policy that should be enforced. It should be supported by nursing management and supported by the executive staff at your hospital, because you might be leaving a lot of dollars on the table with those services. That time, again, time of service versus time of documentation, it can create great conflicts in the medical record to the point that something almost isn't billable because of it. There again, what we just talked about, the template auto population, it's as big a concern in the nursing documentation as it is in the provider documentation. Ancillary staff documentation requirements and therapies of time-based codes. If there's no documentation of time for a time-based code, you can't report it. Nutrition staff, documentation requirements and the qualified staff, and identification of qualified staff within their documentation. In radiology, code descriptions, number of views, the combination codes is a big thing, unbundling, specifically in the CT scan area, and then is something a screening versus a diagnostic. That has to be very clear, and it has to be very clear in the Chargemaster and the correct codes selected. Laboratory, unbundling, modifiers, medical necessity. Comes up on every review that we do. Emergency departments, sometimes EMTALA issues, definitely infusions, injections, and hydration. Those procedures that we talked about before, do we have an E&M and a procedure? And then the facility level criteria, in that we see issues with what we call double dipping. You can't include in your facility level criteria anything related to a separately billed charge. So an IV start and you're billing an infusion, that IV start should not be included in your facility level criteria. For that patient, if you have an IV start and the patient does not have a billable infusion or injection code, then it's appropriate to include. So just so nursing staff understand that. But anything related to a laceration repair or any other type of procedure, transfusion, CPR, all those things that can be separately billed should not be part of your facility level criteria. Billing staff, admission staff, registration staff, admission status discrepancy, inpatient versus observation. We see people admitted to the wrong status versus the orders, date discrepancies. They need to understand preventative services, time frames, screening versus diagnostic, modifiers, that communication I talked about early on, you know, that with the coding staff, it is so essential. And sharing and reviewing RTPs and denials with the coding, between the coding staff and billing staff. If you want clean claims, if you want to get rid of errors, involve the right people. We don't want to just keep fixing errors and fixing errors and fixing them. You got to get the right people to the table, whether that involves nursing or lab, radiology, the providers, coders, billers. Get the right people to the table so we can eliminate these errors so we're not repeating them over and over again. Outsourced billing, same as coding. Reviews imperative. If you don't know what your outsourced billing company is doing, you better be reviewing it. Obviously, internally, you're going to catch some things, but end of year one, you should be having an external review, and then dependent on your findings, perhaps periodic reviews going forward. Chargemaster, keep it clean. Clean out those codes that are no longer valid. Every year, the departments should be going through any coding updates, deleting codes, adding codes, discussing codes, being aware of units. Sometimes there is a change in units in those descriptions. We frequently see the units reported as the units in the way the drug is stocked in your facility. Medicare guidelines are very clear that the units on the claim are to be reported per the HCPCS code definition, not the way you stock it. So you have to do that conversion factor within your Chargemaster to report it correctly. If you're adding new procedures in your facility, make sure the appropriate charges get added to your Chargemaster. Policies, you need internal compliance policies on pricing, technical versus professional, all these areas. Room and board, what's included, what's excluded, carving out of observation hours, carving out those separately reportable services when they require active monitoring. There's another big area. But where are things getting assigned in the general ledger? It's another portion that while we don't review general ledger assignments when doing coding reviews, we certainly find when we're doing billing reviews and business office assessments, they find a significant problem with where things are assigned in the general ledger and contractuals and all of those types of issues. So, running out of time here. So the goals, coding, collaboration between people, between staff, between departments, equals in compliance. I mean, that's really the bottom line. We want you to keep the money that you've received. That's really the bottom line. And we want you to be reimbursed for what you're entitled to be reimbursed. So it's a communicate and commit to the challenge because we know it's a challenge. And that's the end of my presentation, Angie.
Thank you so much, Sue. This was wonderful. I'm going to ask if I can keep you here for a minute, Sue, just in case we...
You sure can.
Thank you so much. We've got 3 o'clock, and we know some folks have to take off and for other commitments at 3. However, I want to direct everyone's attention to the survey link, which if you're a person who is going to be requesting continuing education credits, you use that link to tell me which kind of credits you want, and we'll send the certificates for that. And then also we did want to offer a little bit of time for Q&A, so I'm going to open up the lines and I'm going to unmute everyone who's able to stay. And when I unmute you, if you can just please remute yourself right away and then unmute yourself to interact. Because I imagine we might have some questions and I want I might remute you if you make a lot of noise when I unmute you. We're just working through this. But I want everyone to have a chance. And we also have the chat and questions feature that will help you. So I like voice questions. I prefer to question that way we can still get it. So I think everyone's opened up. If you've got a question, go ahead and share. There's a lot of great content. I like those top 10 lists. Those are always good to run through, especially. First question from you. We need an icebreaker. Everyone wants to hear everyone else's questions, but no one wants to go the way it always goes.
Whoops.
Okay, here's one through the chat. Thank you. This is coming from Langdon. When you said that neb treatments should be billed as a DME, if we don't have a DME NPI, should that cost be rolled into the ENN code level for that visit? Also, the medication that is used.
Okay, I think, I want to make sure everyone understands this. It's not the nebulizer treatment that needs to be billed to the DME. It's the albuterol, the HCPCS codes for the inhaled albuterol is very specific in the title, is a DME code. So it's the charge and the service per se of the albuterol should be rolled into your nebulizer treatment. It should be, included. It's included in the nebulizer treatment. So if you, to report the albuterol, specifically the HCPCS code, separately, it gets billed through it would be billed through a DME license. And that is primarily because of the home nebulizer business. So the patients, when you're getting their albuterol for home to use in their nebulizer machines, the DME companies are the ones billing it. So that's the only time it's covered. But it's not the nebulizer treatment itself. You can bill for that.
All right, great question. Thanks, Langdon. So can you think of any common questions that you frequently get? I imagine you included those in the slides in the content.
Oh, I tried.
Yeah.
One of the things I hear, say, here's a variation between CMS and the CPT book. A few years ago, the CPT book came out and said you could bill one initial infusion or injection service per day. And Medicare, for previous to that, had always been one per encounter. Medicare considers an encounter an entire outpatient encounter. So if you came to ED, were treated in ED, and then got admitted to observation, and you were in observation for 48 hours, from the time of admission to ED till the time of discharge from observation is considered an outpatient encounter. It all goes on one claim. So anyway, it had always been one initial service for the entire encounter, and then CPT came out and said, no, you can do one per day. And Medicare rather rapidly came out and said, no, we don't agree with that. We are only going to reimburse one initial infusion or injection service per encounter. So sometimes you will get that discrepancy, and you have to bill as you have, if you want to get paid, you got to do it the way Medicare says. And most payers have gone along with that. Now, talking about the nebulizer treatments, that one has changed on a yearly basis. We never know what to say from one year to the next because of the verbiage is so gray. From last year and the year before, they were on that encounter issue too, on only one nebulizer treatment per encounter. And this year, the verbiage changed a little bit, so we have decided that they mean, okay, if they're in the patient room, give a nebulizer treatment, leave the patient room, come back 8 hours later and give another nebulizer treatment that you can report to. There are medically unlikely edits that you have to review. I think it's like 3 is the allowable per day, but very clearly that they have to be considered separate episodes, not within the patients in the room, and you give them one and then you repeat it because they're not getting better. And it's been an up and down issue for the last about 5 years. So sometimes you just have to, we have to make a determination of how we're going to interpret guidelines.
Thanks. So we've got another question that came in from Watford City. Can you bill a facility E&M along with the procedure, or do you still need to consider the documentation as you would when coding the professional fee?
For the facility side, we look at it exactly the same as we do for the professional side. However, you're taking different circumstances into account in that, you can't rely just on the physician documentation to report the facility side. So there might be times when they had a procedure, like laceration repair is the one that, we kind of use the most, but, and maybe they gave them a pain medication. And so the patient got very nauseous from the pain medication for the laceration. The physician, it was pretty straightforward. They came in and they just did, the laceration repair for the most part. And that's all, they're going to should bill is the procedure. But maybe on the hospital side, that patient got very nauseous, and they required just increased monitoring, or maybe their blood pressure dropped. There can just be whatever circumstances. So you definitely can look at them individually, and there's going to be circumstances where they'll be different, that maybe the hospital side is just going to bill the procedure, the physician's going to bill an E&M and the procedure, or the other way around. But most of the time, it's going to be so straightforward because we're talking minor procedures. We're usually looking at foreign body removals, incision and drainage, laceration repairs, maybe epistaxis control, those kinds of issues that are pretty straightforward. So, but it's not a rule. It's not a rule that if you only bill a procedure for the physician, you can only bill a procedure for the facility, or the other way around.
Okay, I've got 2 more questions here. This one says, I'm confused in the ED when can we code a procedure, and in E&M and when we can't. Okay,
this is my classic example. If you've heard me talk before, you've probably heard this. So everybody that's from NDH, IMA, or a client that we've been with, I apologize. But say the patient comes in and they fell out of a tree, and they hit their head and hit their elbow and scraped their leg. And so the provider is doing a head-to-toe exam and wants the nurses to do neuro checks for, 3 times or whatever because they hit their head. And he orders maybe a head CT and an elbow x-ray and a knee x-ray. And in the end, the only procedure that's done is a laceration repair on the leg. This one is just, very clear. There was, and you did a head-to-toe, he, she, whatever, did a head-to-toe examination due to the various injuries or potential injuries due to the fall. And so this is a very good example of we're going to have a separately identifiable E&M of all these areas, body systems, and tests that were done and reviewed unrelated to the laceration repair. And on the facility side, it's going to be the same, type of issue more than likely because they're doing neuro checks, they're doing repeat vitals, and, probably escorting the patient back and forth, radiology, ordering labs, those kinds of issues. So that's a, classic case of when you'd have a separately identifiable E&M, or it might be an elderly patient. and they came in because of a fall and they had a laceration. But they're like, I don't really know why I fell. I don't know what happened. And so they're doing kind of that neural examination there too. Or they're on a lot of medications, and so they're doing some lab work and assessing that, and maybe having the nurses, walk with the patient to see how steady and stable they are. And so a case like that, you'd also have a separately identifiable. It's the patient that comes in and cuts their finger, while they were doing dishes, and oh, yep, there's a laceration. It's deep enough, big enough, we have to do a repair. And just pretty straightforward. Those are the ones that you're not going to have a separately identifiable E&M in most circumstances.
Okay, thanks. One more here. This is kind of a long one. So, question asker of the previous question said, thanks, that helps. So the next question, Carrie, you might have to unmute yourself. This is kind of a long one, so if any clarification is needed. So the question is, regarding the infusion change, we are getting claims denied with only billing 1 per encounter instead of 1 per day with Medicaid. What should we do? Do we follow what Medicaid says for their claims and follow what Medicare says? The stickler is when Medicare is primary and Medicaid is secondary. Thank you.
Okay, that's the first I've heard of that. So I don't have an answer. I've not seen anything that Medicare says you need, or Medicaid says you need a new infusion or injection initial if you have more than 1 date of service. If at all possible, whoever it is, can you find out, do you have my email address?
Carrie, you look like you're unmuted. No, I can make sure she has. Oh, now she's right.
Okay. I guess I'd have to look at exactly what you're looking at. And, is this Carrie Buchholz?
Mm-hmm.
Carrie, why don't you just send me what you're looking at, because I'm not aware of that. I don't believe we've heard that here.
Okay, so that looks like the end of the questions that we have so far. So if anyone wants to ask another one by voice or put it in the questions or the chat, we'll hold on another minute before we adjourn. It's great to have these questions. This interaction is really helpful for the group to all learn from each other's experiences, and so this is great. Thanks for those of you who are pitching in questions. Okay, so to close then, we have the reminder of the 2nd August coding webinar that the Flex program is supporting. Rhonda spoke with us about this one at the beginning of our webinar, but our building was having a fire drill and I operated everything at that moment. So Thursday the 31st, please register and join us if you're able. That one sounds excellent too. And then if anyone hasn't seen the chat section of the webinar here that we've got right now. So do you want to can you give control back to me?
Oh, sure. Did that work?
I think it's coming. Oh, okay. So it's not.
Okay, just wait.
I think you can all see it on your webinar dashboard. So please, if you need continuing ed questions, give us the information, and that's the way you'll receive them. So continuing ed credits are available for this participation in this live webinar today, and I'm going to close that down in about 24 hours. So get your responses in, and even if you're not requesting credits, we would love you to share feedback.
I switched it now, Angie.
Mind showing up there?
Yep.
Okay, perfect. Thanks, Sue. So if you can share feedback with us as well. And again, thank you, Sue, for your time and preparing all this content with us and sharing it. It's really been great. Our hospitals always tell us what great and educational experiences the chart audits are, and how helpful those projects are for really staff at all levels.
Well, thank you for inviting us.
Yeah, we're so happy to have you. And thanks everyone for joining, and hope to see you at the end of the month. Thanks so much. Bye-bye.